Good day, viewers. I'm Seth Muli, and welcome to another edition of The Wellness Effect. In this week's episode, we continue to look at the National Health Insurance Act, also known as the NHI. Professor Alex van den Heever, thank you for joining us today. We've been discussing in other episodes the National Health Insurance Act, but also universal healthcare. And we heard the position of Bankmed, which is one of South Africa's largest medical schemes. But I wanted to get from you, based on your experience working in public sector and the private sector, where are we at with this act?
The bill has been signed by the president or assented to, and so it's an act, but it hasn't been promulgated yet, so nothing's in effect. But the act is basically now in place, and effectively it's now in the hands of government to theoretically create regulations and to begin an implementation process. But for any provision of the act to be implemented, it requires that the president promulgates it.
Now, my understanding of universal healthcare, there's been a lot of discussion around universal healthcare. Is NHI the vehicle to drive us towards universal healthcare?
So difficult question. So universal health coverage or health access to universal health care is an objective. And the objective does not require national health insurance in order to be achieved. It can be achieved in many different ways, and around the world, virtually every single health system has a kind of a hybrid design in which there is a mixture of public and private, regulated markets in some cases, public institutions, and a mix of the two. So that's when the objective is actually the focus. National health insurance it's kind of anomalous in that it's a proposal in which it wants to squeeze all the entire objective is to be achieved through a single vehicle. And that's the unusual nature of this particular proposal. So it is distinct from the concept of universal health coverage, because effectively we have universal health coverage because everybody's covered one way or another. They're either covered through a medical scheme or they're covered for free in the public sector. So so we already have a coverage objective. The question is the quality of the coverage and other dimensions of continuous improvement that are necessary in health systems that really require an ongoing kind of project of government and society. But NHI isn't a continuous improvement in the system. It is a stepwise adjustment of the current provincial health services in the public sector and the medical scheme system, in that both would theoretically be disrupted with this proposal and kind of squashed basically into this national fund structure and arrangement. So it is quite unusual. And there's a question as to whether or not the proposal will actually result in a reduction in coverage rather than an improvement.
Sure. And maybe let's chat through the concerns that have been raised by various players in the space around NHI. What are these concerns?
So the concerns can be both around the proposed restructuring of the public sector and concerns around coverage in the private sector. So if I begin with the latter, in the private sector, the issue is that people are essentially paying for themselves. They're covering their own healthcare through their own post-tax disposable incomes.
Correct.
It's not government money, it's private money. There is a subsidy that comes in, but it's relatively small compared to the overall expenditure. And that subsidy is really in lieu of the fact that you're not using the public sector. So the public sector is not free to medical scheme members. So there's essentially a financial subsidy that's there to keep people on medical schemes, because otherwise they'd be using the public sector and having to pay for it.
Right.
That's the requirement currently. There's no framework that suggests that anything different would be done in the future. The public sector, so the proposal involves saying whatever the national health insurance arrangement covers can't be covered by a medical scheme. So it involves basically prohibiting certain forms of coverage in the private sector, which is unusual because it's actually saying you can't cover yourself. A bit like saying you can't buy your own solar panel. You can't buy private security. You can't pay for your own education in a private school. And it's kind of treating the concept of your own disposable income as part of the public budget. It's not. So the concern there is the prohibition on the basis that there is an attempt to establish equity in the health system. The logic doesn't make sense because you don't need to remove somebody's coverage in order to improve public services. And that includes improving public services through, if you wanted to use additional taxes and raise further money through the government, you can do it and you would get basically more bang for your buck if you didn't crash coverage in the private sector, because now you're trying to pull all of those people, 9 million extra people, into the public sector, and the system basically isn't organized for that. And it's incredibly complex to try and mix the two provider systems at this point. The state is not in any position to be able to buy private care in a coherent manner. It can barely buy public care. So that's one of the concerns, is the prohibition. It seems a draconian act, chasing an objective that is completely unnecessary. Achievement of better resourcing of the public sector does not require the destruction of the private sector and coverage in the private sector. This is what people can't understand. And I can't understand it as somebody who's worked in this field and social security for 30 years. It doesn't make sense. The public sector restructuring involves essentially taking healthcare as a function away from the provinces and shifting it up to national government and centralizing decision-making and planning, etc., in a relatively shallow structure that's encompassed within the Act itself. The concern there is that, in fact, you take a very complex system and you now also try and pull that into the national tier of government. Everything changes. Now, these kinds of drastic changes, whether in the private sector or the public sector, are incredibly difficult to get right because you really don't have the machinery in place to do these perform these complex functions. And so the concern really is that government has a proposal on the table for which it has very limited capability to implement, is very unlikely to implement. The whole restructuring of the multi-level system of government is potentially quite far beyond the capability of government at this point and would serve no purpose because you can properly regulate the provinces without shifting the function to national government. This is what also doesn't make sense. Why do that? If you can achieve your objective more efficiently through strategic interventions from national into the provinces, many health systems around the world function with the equivalent of our provincial health systems. They're decentralized, evolved structures. It's better that way. They're held more accountable at a local level. What we have to do is look at why they haven't been working at a local level and how to deal with the accountability failures within the system. You don't deal with it by shifting it up to national and then having a very, very weak accountability structure, which is a minister appointing everything in the kitchen sink into this fund, doesn't create a strong accountability structure. It creates an incredibly weak accountability structure in what is in essence a monopoly fund and structure. But not only a monopoly for private, but also a monopoly in the public. You have no choice. If this system fails, you have very little recourse. So there is, it's a very, very fragile framework, very top-heavy in terms of control, and assumes that you can actually achieve very, very complex functions in the health system without localized accountability. So this is the problem. Is that it's a very poor design overall, very unlikely to be implemented. And the private sector side requires that they increase taxes quite drastically in order to be able to cover a group of people that already is covered. This is not a universal coverage strategy that I've certainly seen in any country, because typically if you have a problem in terms of coverage, you select the group that is not having access to coverage and you create a strategy to get them covered. Here's the assumption is that we can introduce additional taxes equivalent to what people are spending on their medical schemes, add this to the public budget, and then pull all medical scheme members into the system and assume that somehow everybody's going to be better off. It just can't be done. So it doesn't make sense. You can increase taxes, but then spend it on people who are not in medical schemes. You don't have to bring 9 million people into the public sector in order to make a tax increase work. But the problem of increasing taxes dramatically is a very big problem that government faces, and around the world. You just can't do it. So you've seen Kenya at the moment, and you can go as far back as the American Revolution. You introduce taxes that people regard as unfair, they don't pay them, and they rebel. This has been a consistent trend around the world, which is why when taxes are changed, they tend to be incremental, very carefully thought through, and most of the time your improvement in government revenue comes from economic growth, which has stagnated in South Africa. And so government's not in a position to get more money through tax rate increases. You hit what's called a Laffer curve ceiling. There's a ceiling at which higher tax rates get you less revenue than you got with lower tax rates. So we're basically at the Laffer curve ceilings on most of our tax bases. So this is the situation we're in. If we got additional government revenue, government also has to prioritize health over other functions. It's unlikely that they're going to give special interest, special focus to healthcare going forward. There are just too many other very, very important priorities. But that's a government decision, cabinet, etc., and parliament. And so there's no way that even a tax increase that you introduce goes to health. Doesn't work like that. The tax system is distinct from the system of appropriations, and that's the world we live in.
Thank you for shedding light on a number of issues around the NHI. You've mentioned government capacity. You've mentioned the issue of the fund itself, but it's now Act. Can it be changed? What can we do as a broader society to question the intentions of the NHI Act?
So it's important to note that the NHI framework, the policy framework, is not implemented by this Act on its own. Only a part of the framework is. It actually requires quite a lot to happen outside of this Act. And it's questionable as to whether or not those would be implemented. So the fact that the Act is passed doesn't mean that the policy is actually in place or can be in place just through this Act. It requires tax increases. It requires a whole process of function shifts from province to national, none of which is in the Act. So that's the first issue. What is in the Act is the proposal to potentially prohibit coverage, medical scheme coverage, for anything that is covered by the National Health Insurance Fund. Technically, this is very far into the future where they'll have their ducks in a row sufficiently to even have benefits in this fund. But the Act itself is very unclear as to what it actually means in the way that it is worded, this complementary coverage issue. It says medical schemes can only provide complementary coverage to what is covered through the National Health Insurance Fund, but there's no definition of any value to explain what they refer to as complementary coverage. So given that uncertainty, there's a lot that would still have to be interpreted in this Act, and I expect that those would be interpreted in the courts. Because you cannot create an enabling provision that is ambiguous and unclear and expect to clarify it in regulations, because then you're giving the powers of Parliament to the minister. So whether at the stroke of a pen they can destroy an entire industry. That can't be what people have assented to. So so part of what's very likely to happen is that the Act itself will be challenged in court. I think there will be multiple challenges to the constitutionality of the Act, to its which includes basically its rationality, its reasonableness, because it's proposing to take people's right to healthcare away as part of this proposal, on the assumption that it's actually going to improve coverage. And you can't really improve coverage by taking coverage away. And you can't take it away from people who are basically paying for it themselves. So all of these things have to be tested. That's it's a protected right in terms of the Bill of Rights, so there will be a challenge along those lines. So I expect court challenges to happen immediately before any major implementation occurs, and it probably won't be one, it will probably be 5 or 6. And then I think that this will be an ongoing process for quite a while, because all of these challenges are likely to end up at the Constitutional Court.
In an ideal world where you're giving input at a ministerial level, what would your input be? What would your advice be in restructuring this NHI Act?
I would abandon it in its entirety. It is essentially an extremely poor policy framework. This is not how you reorganize your health system. We do have a National Health Act, which and lots of legislation that deals with healthcare in South Africa. So at the government at a national level and provincial level have significant powers to modify and deepen the health system. Essentially, what you require is that you're focused on where the weaknesses are within the system in terms of delivery and productivity of expenditure and also resourcing and how you prioritize your resources. I mean, do you provide more nurses or more doctors? Do you create a structure which is more nurse-based, doctor-based, which is very expensive? How do you improve all of that? This is an ongoing process. It's not a one big reform. So if I were advising, I would actually start focusing on what we need to change. It's important to note that since 2004, we've had no systemic reform of the health system at all. It's been completely dead. That's 20 years of nothing. And the National Health Insurance Act itself doesn't address many of the problems that have emerged within the system. It's the national government and many provincial governments have just done nothing. So we have failing performance at the provincial level, failing performance at the national level, very, very weak decision-making, very legislation that hasn't been changed or modified for a long period of time. So legislation and key policy frameworks are a bit like building a house or building a property. You've got maintenance that you need to do. Maintenance in legislation is every 2 years you have an amendment that basically deals with major strategic issues, and you're ongoing. You never create a perfect piece of legislation, and where you then occasionally you have a stepwise adjustment, and we've had nothing. So we're basically 20 years behind the kind of incremental adjustments that we should have been making all the way through. We don't have a properly developed district health system. We have a very, very poor governance framework for our public hospitals. We don't have a proper governance framework for forensic services. We don't have, and as a consequence, all of these healthcare services don't function well. We don't have a proper framework for emergency medical services. We still have, that's one where you would want to unify between public and private EMS, that we don't have private ambulances driving up and taking you to a private hospital and public sector ambulances coming half an hour later and taking you to a public facility. It doesn't quite happen like that. Sometimes the private ambulances take you to the public facility. That's wrong. We've had 30 years to think about this problem and nothing has happened. So what you see is very, very lazy policy making, people saying lots of populist things, but actually never changing anything of material value in the system. That's what needs to change. I don't think we've had leadership capable of doing that, capable of strategizing, focusing on what we need to change in the system and getting it done. What we've had is people who don't focus on that, talk a lot about a bunch of things and never do anything.
So there's I like what you mentioned, there's an implementation element that we need to focus on prior to focusing on NHI Act and focusing on maybe the things that need to have been fixed over the last 24 to 30 years.
Yeah, so first of all, there is strategy. So for instance, I'll give you one example. Every time somebody says, well, a provincial health service is overwhelmed and underperforming, and they talk about migrants. Oh, well, we have lots of people from Zimbabwe coming over for maternity care or something. Now that, I mean, I was part of the SMTs converting our previous provinces into the current provincial health administrations. Every one of those things was identified 30 years ago, 1994. So what you'd have expected, let's look at the regional context, is that you would have treaties in place to deal with financing people who basically cross borders to come to your facilities, which means you've got in place agreements of reimbursement with Zimbabwe, with Mozambique, with everybody on our borders. And in that treaty, we're part of a customs union. We basically have a revenue sharing arrangement and basically a cost adjustment back to our provincial health departments for these cross-boundary flows. What I'm saying can't be done by provinces on their own. It requires national government to get their act together and do this. 30 years is, yeah, you can't do this overnight, but 30 years is a long time to get this done. There's not a single province probably outside the Western Cape, that can actually raise an invoice against a foreign patient, let alone a proper invoice against a private patient and any public patient. So the problem now is that they complain about, these provinces complain about foreigners using public healthcare services, but you ask them for how much do they cost? Where's the invoice? How's your IT system supporting allocation of costs, etc., and billing people who can pay? Now it would be a foreign country, let alone not a medical scheme. Nothing. The billing systems are primitive, half implemented, and yet we're in a country where in the private sector they went completely electronic invoicing from 2000, 2001. So 2000, 2001, 24 years later, our public system hasn't even caught up with the private sector in something as basic as patient administration. And if they had, you could start to connect that to your regional context. Now, I'm giving you one issue out of a myriad, but nothing happens. Human resources. We don't have a human resource strategy of any coherence because government doesn't even have, and it failed to collect all the information on health professionals in South Africa. It doesn't know how many people are in the private sector. It talks about private sector taking public sector resources away, but it hasn't got a single study or data to actually test or analyze that. Human resource strategies are done country by country by country. You have to do them. You have to make sure that we don't have an undersupply of key health professionals. You have to subsidize that if there's an undersupply, but you also have to be able to absorb what you subsidize. We've done none of that. So we subsidize in a chaotic manner. We overproduce doctors. We can't absorb them into the system. And because there's the whole system of planning and actually thinking about human resource health professional management in South Africa is non-existent. This stuff is bread and butter stuff that should be done. So now that's human resources, that's the regional context. And I've mentioned EMS, I mentioned the hospitals and hospital governance. We should have people who are running our facilities. So we take a 3 billion rand hospital and we put somebody who shouldn't be running a corner cafe in charge of that 3 billion rand organization. We have unprofessional managers in charge of major, highly complex, very, very difficult to manage organizations. We don't have specialized skills in financial management of healthcare facilities.
So, Professor, who is fighting against the NHI Act?
So at the moment, it's a number of different players within the system, not necessarily working together, but they are all individually extremely concerned. So various hospital groups, medical doctors associations, the medical scheme associations, and as far as I can tell, as well, business and some unions. So it's quite a wide spectrum of groupings. And they're really focusing on the issues that harm them that are within this bill. That's to be expected in act. And but I think that at some point it will probably come together. I think that there's a lot of people that are harmed, and I think that really it's an issue of making sure that these players are properly supported in their actions that they're taking forward. Because at this point in time, it really takes collective action in some way to make sure that government is held to account for the policies it tries to implement. It shouldn't implement bad policy and it shouldn't be permitted to do so. That's what the courts are there for.
Thank you so much for such an enlightening and engaging conversation.
My pleasure.
This topic is such a great reminder for us to keep ourselves informed. And remember to subscribe to our YouTube channel. Proudly brought to you by Bankmed.